That's the triglycerides. So that's a different component. The first thing the body makes is VLDL, or very low density lipoprotein. That gets converted to LDL. LDL is more of the cholesterol particle. VLDL is more of the fat particle.
Hmm. And then we've got HDL. How is that different?
HDL is the good cholesterol. So that's the high density lipoprotein. That takes the cholesterol from the periphery and brings it back to the liver for disposal. So it's kind of the reverse cholesterol transport, we call it. That's the good stuff.
Okay, okay. And then the other thing I want to cover off on is ApoB. So what is ApoB and how does that tie into this?
Um, so ApoB is a more accurate measure of all of the bad particles. So that includes LDL, VLDL, and other particles that are missed in that measurement. So
Hmm.
ApoB is another more accurate way of measuring all of the bad particles in the bloodstream beyond just LDL.
Yeah. And so I would imagine LDL and ApoB correlate with cardiovascular disease risk. People who get cardiovascular disease tend to have higher levels of both of these things. Is that's generally true?
Yes, but the relationship is very weak,
Mm,
and we don't usually, again, think very strongly that that's our primary risk factor. So it's not a good marker of risk.
mhm.
It's just not a strong marker. It's a very big misconception among a lot of people.
I see. I see. Okay. And then I want to talk about triglycerides a little bit. So, for example, your liver can make triglycerides, and we can talk about what that is. A common marker that I hear people refer to in terms of being one way to gauge metabolic health is the triglyceride to HDL ratio. So, what is that, and what does it actually tell us about overall metabolic health?
So yeah, triglycerides are bad particles. They're inflammatory. They're the fats. So it's kind of like the bad particles, the fat particles divided by the good particles, the HDL. So if your HDL, your good cholesterol is high, that's good for metabolic health. People who exercise a lot have good health overall, have good HDL. And triglycerides are the fats and the inflammatory markers. And if those are high and your HDL is low, your ratio is very high. So that's kind of a bad over good relationship. And the more the bad is, or the lower the good is, the worse those numbers become.
I see. So if your triglycerides are, if you're relatively healthy, you're metabolically healthy and fit, your triglycerides will tend to be low, your HDL will tend to be higher. The triglyceride HDL ratio will be low, and we tend to think of that as a good thing. And then if you're unhealthy, we see the opposite relationship. That number goes up. Now, traditionally, I would assume, based on sort of the traditional cardiology beliefs that are out there that are around how cardiovascular disease starts. If someone is healthy, then you would expect their triglyceride HDL to be low, and you would also expect their LDL to be low. But I think what you're going to tell us is there's actually cases where people are metabolically healthy, even though their LDL is quite high.
Yes.
And so so sort of in the classic cardiology literature, looking at atherosclerosis, the relationship between these cholesterol and triglyceride markers and heart disease. When people study these associations and they find that there's a statistically significant, but you said weak link, say, between or weak association between LDL, ApoB, and cardiovascular disease, is that literature mostly looking at people in general? Is it mostly looking at people that already have issues like high blood pressure and plaque buildup, or is it looking at healthy people and sorting these different groups out from each other?
So yeah, I mean, whenever you look at a population of people, it's not everybody conforms to that. So we talk about population-based medicine, where we kind of look at risk factors in general, or we look at individuals, and it doesn't always correlate. For example, some people with diabetes don't get heart disease,
Mm-hmm.
but a lot do. So we think diabetes is a risk factor, but in a given individual, they can have raging diabetes and their coronaries are completely clear. So we always have to look beyond the risk factors to the individual, and that's why we do the CT scans and the plaque assessment to see what's going on in the arteries, not just what should be going on in the arteries.
Mm-hmm. So based on what you've told me so far, it sounds like, as a cardiologist, if someone was old enough, whatever that means, in their middle age, and they want to get an assessment of their heart and cardiovascular health, it sounds like you can't solely rely on biomarkers like LDL and ApoB. What would be like the number one or top couple things you would do to assess someone, say, who's middle-aged in terms of what their plaque buildup looks like or what their overall cardiovascular disease risk actually is?
Yeah, so I recommend, and so does the American Heart Association and the American College of Cardiology, to do what's called a calcium scan, to do a simple scan of the heart. It's done with a CT scanner. It's very, very easy to do. It just takes a couple minutes, and it looks for plaque buildup in the arteries. And if you're one of those people that have a lot of plaque, regardless of your LDL, we've got to get on top of that. And if you're somebody who has a high LDL and a lot of bad cholesterol and your coronaries are completely clear, we say you don't need to treat it for the next 5 years. Those are the guidelines.
So that's interesting. So someone in my family who's almost approaching 60 recently came back and they were talking to me, and their doctor said, your LDL is too high. We need to get you on a statin right now. And I asked her, what did your calcium scan look like? What do your arteries look like? And she said, I've never gotten one. And I said, never? Not since you were 40? Does that surprise you? And would you, as a cardiologist, would you put someone on a statin not having looked at that type of scan?
I mean, unfortunately, there's still a lot of doctors who just go with the numbers and say, oh, your LDL is high, let's put you on a cholesterol medicine. And that's never been the guidelines, actually. But that's just a not natural reflex, is that your cholesterol is high, let's just lower it. But again, if you have no plaque, you're not treating, you're treating a number, you're not treating your body, and you're taking a drug that you don't need. So I'm not surprised, but it's unfortunate that we haven't moved beyond that.
And so give us a very quick rundown how statins actually work. They're used to lower LDL, but what are they actually doing, and how effective are they really?
Yeah, so statins lower LDL by blocking production of cholesterol in your liver. So that's where we make all of our cholesterol, is in our liver. We absorb about 15% of our cholesterol in our diet, and about 85% is made in the liver. So the vast majority would be in the liver, and statins block that absorption. So that's really how they work, and they're very effective. They lower cholesterol by about 30 to 50%. So they cut that LDL cholesterol in half in many patients, and we think that's a good thing if they have plaque, and we're trying to treat the plaque, because the minute the cholesterol drops by 50%, the liver is like saying, hey, I want more cholesterol, and it starts to look for cholesterol from the bloodstream, and it pulls it out of the bloodstream. So that's where the reverse cholesterol transport comes in. So the response to a statin is to lower LDL cholesterol by about half. If you use a high intensity statin. They also lower inflammation, and they also reverse plaque in the arteries. We know that. We've seen that happen in multiple trials now, where the arteries look better after 1 to 2 years of being on a statin. They have less plaque in them.
So it sounds like your basic approach as a cardiologist is, if someone has plaque buildup, as shown by one of these calcium scans, and their LDL is high, then you will likely put them on a statin to lower those LDL numbers and hopefully reverse some of that plaque buildup. But if their calcium scan comes back clear and there's no plaque buildup, even though their LDL is quote unquote high, you probably would not put them on a statin in that case.
Yes, that's correct.
And so how else can we change LDL levels in the body from a dietary perspective? My understanding is that, for example, polyunsaturated fatty acids will tend to be associated. If you boost the intake of those, that will tend to lower LDL. Is that true? And is that or are there other dietary ways to change LDL levels?
There are dietary ways, but the problem with diet is that it only controls about 15% of the cholesterol on average. So even if you went from a relatively poor diet to an exceptional diet, your LDL is only going down by about 15%.
And so related to that, what about dietary cholesterol? A very, very widespread belief out there is that if you start eating more cholesterol or foods with high cholesterol levels, that will significantly boost your blood cholesterol levels. What's the relationship between dietary cholesterol intake and the actual serum cholesterol that would be measured inside of a person's blood?
Yeah, it's a weak relationship. There is definitely some increase, but it's very modest. Since dietary cholesterol only accounts for 15% of your total cholesterol, dietary cholesterol accounts for a very small percentage.